Okay, looks like we have a good number of folks on, so I'm going to get started. Good afternoon, everybody. I'm Tyler Manier. I'm Vice President of External Affairs at the Quality Institute, and it's my pleasure to serve as your moderator for today's event, Building Bridges Between Healthcare and Public Health. Just a couple of housekeeping items before we get started. All of our phone lines will be muted for the duration of the program, just to limit background noise. You may ask questions at the conclusion of our panel by typing into the chat box, or if you'd like us to unmute your line, you can raise your hand by clicking the controls in the webinar controls at the bottom there. And please know that today's webinar is being recorded and a copy will be posted to our website at njhcqi.org later today. And earlier this year, we released Emerging from COVID-19, an action plan for a healthier state. It includes 24 recommendations made by a multi-stakeholder work group of healthcare leaders from across the state. And you can use that short link right there to access the action plan. I hope everybody gets a chance to read it. And one key area of the action plan is revitalizing and reorganizing our public health infrastructure. Public health is a critical component to a healthy society, yet the public is largely unclear on what public health is and has a fairly limited understanding of what local health departments are for and what they're responsible for. The pandemic highlighted a great need to create stronger alliances among public health departments and the network of agencies charged with responding in an emergency and other community organizations. So today we brought together a panel of local, county, state, and national experts to talk to us about how we can build on the momentum that we've gained during the pandemic and really continue to strengthen those ties between healthcare and public health. So I'd like to ask each of our speakers to introduce themselves quickly. We'll go in alphabetical order, starting with Jeannette.
Hi, everyone. Dr. Jeannette Kowalik, Director of Policy Development at the Trust for America's Health.
Thank you, Jeannette. And Paul?
Thanks, Tyler. Good afternoon, everyone. I'm Paul Lambrecht. I'm Vice President of Quality and Patient Safety for Inspira Health.
Thanks, Paul. Julie?
Good afternoon, everyone. My name is Julie Petex, and I serve as the State Coordinator for the New Jersey Medical Reserve Corps.
Thanks, Julie. Kathleen?
Sure. Hi, I'm Kathleen Noonan. I'm the CEO for the Camden Coalition.
Thanks. And last but not least, Charlene.
Good afternoon, everyone. I'm Charlene Dungill. I'm the Health Officer and Director of the Department of Public Health in Passaic County.
Great. Thank you all so much and welcome. As I mentioned earlier, we're going to get into some questions for our panelists here, but as you have questions, please type them into the chat box and we will get to as many as we can at the end of our moderated panel. So I'm going to start with Jeannette. Jeannette, as the former Health Commissioner of Milwaukee and now the Director of Policy Development at Trust for America's Health, can you tell us a little bit more about those two roles that you've occupied and how it led you to prioritize equity as a public health issue?
Yes, absolutely. So let's see. I was health commissioner for the city of Milwaukee for about 2 years. So I worked at the Association of Maternal and Child Health Programs in Washington, D.C. from 2016 to 2018. And I left that position to return to my hometown of Milwaukee, Wisconsin, to serve as a health commissioner. I also give a lot of credit to everyone that's still working the front lines in this pandemic. And of course, I came back to my hometown to make a difference and help the health department kind of rebuild. There were a number of issues that had occurred over the years, which created the need for a replacement commissioner. And just knowing the lay of the land in Milwaukee and knowing that Milwaukee had struggled and still struggles with segregation and racism in many ways, shapes, and forms, I knew that I had to do something as commissioner. So I was very vocal about health equity and the need to center community and rebuilding the health department and creating more opportunity for people in general in the city of Milwaukee. So just off top, just making sure that equity was a priority was a part of my strategic visioning for the department. So we pretty much did like a reorganization exercise and created a new structure for the health department. We also revised our mission and vision, and our values pretty much stayed the same, but equity was included, but it wasn't necessarily like meaningful at that point in time. We also had issues with not having a board of health. Previous mayors had eliminated the need for a board of health, and we advocated for there to be a reinstatement of a board of health for the city of Milwaukee. We felt that the board needed to reflect the community that would be served, so we actually wrote the policy for the Board of Health to reflect the diversity of the community. So half of color, and then also representing various aldermanic districts in the city. So there was 15. So we had to make sure that there was good coverage. And then also just acknowledging that some of the initial work for declaring racism as a public health crisis had came out of Wisconsin. My colleague and friend Lillian Payne, she was the one that really helped to push that work forward through the state affiliate of the American Public Health Association. So the Wisconsin Public Health Association, 2 years prior, this County of Milwaukee's Office of African American Affairs had took that work and adopted it for the county, noting there's no county health department. There's 12 local health departments in Milwaukee County. So once the county did that, the city, we were like, okay, it's time. This really opened the door for us to do this. So we created our own policy for the city. It had 5 action items. Of course, in public health, the first thing you do is a needs assessment. And then it moved into various phases. We wanted to model the behavior we saw in employers throughout the area. So assessing our own city departments, our own policies and practices, and diversity of staff across all levels, not just direct service, but from the top down. As we were in the process of doing that, because this was like summer of 2019, of course, a pandemic would happen or start during that time period. So that really accelerated our need to quickly create a pandemic response that was centered in equity. So from the beginning, we were prioritizing collection of race and ethnicity data for our COVID cases and fatalities. And that really helped us to see that there was some huge inequities happening in our community. We saw early on, this was probably our first case was Friday the 13th in March. Maybe about 3 weeks later, we were able to see that most of the cases were concentrated on the north side among African-American middle-aged men. And we were having our daily media briefings, as many of you all were doing, and most of you have dialed back on those daily briefings. But we essentially put it out there that this was happening, and that got picked up by national media. And then we started to see, as other communities started to gather that data, that we were seeing the same trends across the country, whether it was indigenous populations, Latinx populations, various Asian American and Pacific Islander groups, that we were seeing these inequities happen. So we knew that this wasn't because everybody went to the same event, which is normally what you see with epidemiology, but we were seeing the effects of racism playing out through the pandemic. So through social determinants of health, the types of jobs people had, the transportation, the housing that they had, whether they had the money to not work and expose themselves or put themselves at risk for exposure to COVID-19. So we're seeing all of that play out. And, again, I just attribute that to some of those trailblazers, my colleague and friend Lillian Payne, Nicole Brookshire, who was at Milwaukee County's Office of African American Affairs, and all of the other city leaders that came together to rally for us to make sure that we were addressing the elephant in the city, which was racism, and that we were trying to do something about it. So that work really set the stage for the early leadership of the COVID-19 pandemic in Milwaukee. And then, of course, eventually I transitioned back to Washington, D.C. to be the Director of Policy Development at the Trust for America's Health. And I was brought on board to make sure that all the policy development work that we're doing is centered in equity. So I'm happy to be in this role where I can make sure that equity is at the core.
That's amazing. I think that's just a testament to people don't realize that public health departments are doing that level of work in health equity and social determinants of health, and really making that kind of a difference. And It strikes me that your policy was a model for others in the county and in the state. Is that something that's publicly available, the policy that you used?
Yes, yes. So we have all of those materials. We also created an anti-racism plan for our health department as well as all other city departments. That was something that was requested from our alders midpoint through last year. So once all of the social justice demonstrations and protests occurred, they were like, well, what are we doing? What are we going to do to, make this happen more quickly? So we were required to create anti-racism plans. So all of that information is available online. I can provide those links to those resources, but a lot of work went into them to putting them out quickly and then putting them into action.
That would be great. We would love to share those resources with our members. I know a lot of folks would enjoy having those. Thank you. Okay, thank you, Jeannette. Next up, Paul, can you tell us a little bit about how Inspira's pandemic response led you to build even stronger relationships with your local public health officials and organizations in your community?
Absolutely, Todd. Thank you. So I think we've been able to build even stronger relationships in several ways. I think the major factor at the core has to do with relationships, and the relationships that we've managed to build over a period of years working together with our public health partners outside of crisis situations, just in normal day-to-day activities. Inspira has the opportunity to interact with 3 county health departments, Gloucester, Salem, and Cumberland counties, along with the city of Vineland. So as I said, our interactions with them occur routinely with our infection preventionalists and the local public health teams around all types of communicable diseases and the reporting thereof. So it allows our teams really to get to know each other through just standard work. During the pandemic response, there were a few key areas where we worked very closely with our public health partners. And as a result, I think we've built even bigger relationships. In the early part of the response, we had the opportunity to work very closely with the Gloucester County team as our initial COVID case occurred in Gloucester County, our facility in Gloucester County. So obviously we were interacting on a daily basis or even several times a day early on with the Gloucester County team, just talking about how we're managing the patients, how we're coordinating contact tracing, how we were communicating about what was going on. So there's a lot of interaction very, very early on. And then obviously, as case counts continue to increase, we had ongoing communication, obviously regarding approval for testing and sharing of information for contact tracing, keeping in mind that this was far from perfect out of the gate. I mean, we were all navigating this for the first time at this level of urgency. So during that period, Inspira had the opportunity, along with our other acute care partners, to participate in regular briefings with public health and emergency management, just to kind of talk about where everybody was at that point in the response. As the response continued, we began to work with additional public health staff that had been brought on board to assist. So we may have been interacting at times with people we did not know, we had not met yet. So our infection preventionists tried to, do their best to anticipate some of the questions that they may be asked or information that they may need, and try to proactively provide that information in CDRSS, for example, so that the public health team could use that information to assist in their contact tracing efforts. And then as our operation shifted from response to vaccination efforts, we continued to work with our public health partners to assist in getting vaccines out to those who needed it. And initially, we established our 2 vaccination pods at Mullica Hill and Vineland. And our initial focus, at least during the initial 4 weeks of our operation, was the Inspira staff. But once we progressed past that initial 4-week period and opened the pod up to the community, we began to vaccinate those in the community who were also eligible. As the mega site opened up in Gloucester County and they were getting prepared to stand up their operations, members of the team came over and toured our operation at Mullica Hill to see how we had established that operation and to share ideas back and forth to assist them in operating the mega site in Gloucester County. And then as eligible groups for vaccination continued to expand, We continue to collaborate with public health to best leverage our resources and our vaccine availability to meet the greatest needs. So we collaborated with our local public health teams and the superintendents of schools to make vaccinations available for the teachers. I mean, that was the first step in Spearhead into the community to work with public health to begin vaccinating those key populations. That collaboration would expand several weeks later to form the basis of our ongoing outreach work into the schools to vaccinate students. It started off with vaccinating high school students in advance of graduation activities and things like that. And that quickly expanded to the 12 to 16 age category once we received the approval to vaccinate that population. Collaboration continues today around those populations have access challenges. For example, the homeless population and the homebound population. So we're working with public health to identify those in need and how we can best get vaccination out to them. We've done some work in Cumberland County with respect to the city of Bridgeton. Bridgeton is one of those cities in the state that had lower participation rates with respect to vaccination. So looking to see what more we can do from an outreach perspective to get into those types of communities. And then assisting in public vaccination events. We've been working or have worked with Cumberland County, teaming up to provide the Pfizer vaccine so that we're able to vaccinate the 12 to 16 age group as they had availability of Johnson & Johnson vaccine to vaccinate the adult age groups. So partnering in those respects, making sure that we can make vaccinations as available as possible to the community. And today, as the vaccination work continues, we're looking to see how we'll address COVID testing going forward. I understand that some of the resources that have been available for public health, financial resources are coming to a close. So we're looking to see how we can best assess what we're doing today for COVID testing and how we can balance that with assisting the community as well. So I started all my comments talking about relationships, and I think that's the appropriate place to wrap my part of the comments up. I think our ability to respond as we did would have been severely hampered if not for the relationships that we had already built over the prior years. So I guess my comment would be, don't wait until you're in a crisis to try and reach out and build those relationships. Begin to build them today and sustain them today. Again, it might not be perfect, but keeping those lines of communication open when the crisis occurs, it leaves you in a place where you have a friend to call when you need assistance. So I think I'll wrap it up there unless anybody has any questions.
Thanks, Paul. I was going to reiterate that same sentiment that building those relationships before an emergency happens is critical. And then, you know, you have a baseline to work with. And that's what we heard from a lot of our work group members when we were building the COVID-19 action plan, that a lot of those relationships were continuing to be built, and folks really wanted to maintain that level of cooperation and collaboration after the pandemic. That's great. Thank you.
Sure.
Julie, can you tell us a little bit more about signing up to be a Medical Reserve Corps volunteer in New Jersey and really how the program started? Who is eligible to sign up to be a volunteer and how do they help?
Well, thank you. The Medical Reserve Corps was created in the aftermath of 9/11. Volunteers had arrived to offer assistance, but there was no system in place to confirm their identity or credentials. The MRC offers a pre-identified, registered, and trained cadre of volunteers who can be deployed for service. And this is especially critical during emergencies and disasters when paid public health and emergency response assets are overwhelmed. The New Jersey Medical Reserve Corps was established in 2005. We have 24 MRC units, and each county has at least one MRC unit. The units are housed within local health departments, and each unit is led by a unit coordinator, typically the public health nurse or the health educator risk communicator. We have two categories of volunteers. Health professional volunteers include nurses, physicians, pharmacists, dentists, paramedics, EMTs, and veterinarians. Community health volunteers have skills such as language translation, interpretation, information technology, logistics, security, food services, health education, shelter operations, and care assistance to the disabilities, access, and functional needs community. All volunteers play an important role in the MRC, and we accommodate volunteers with special needs. In fact, we have a unit coordinator who has mobility issues. So when she administers vaccines, for example, she is seated. New Jersey MRC volunteers boldly stepped forward to serve their communities during the COVID-19 pandemic. Volunteers ran or supported drive-through and walk-up test sites. They performed warehouse operations, case investigation, contact tracing, callbacks of negative test results, respirator fit testing. They staffed hotlines. They partnered with local food pantries for meal packing and distribution. They made well-check calls to the homebound. They used art to combat social isolation. So early in the pandemic, MRC volunteers assisted in the evacuation of residents from a long-term care facility that was closed for cleaning. And then once vaccines became available, the focus was shifted to vaccinations. We estimate that the total number of COVID-19 tests performed or supported by MRC volunteers since the beginning of the pandemic to date is over 320,000. For vaccines, over 945,000. So New Jersey, we were recently recognized as a national leader and model for COVID-19 vaccine distribution. And also New Jersey was one of the first states in the nation to reach the milestone of 70% of adults being vaccinated. And it's in my assessment that this accomplishment would not have been possible without the hard work, expertise, and true grit of New Jersey Medical Reserve Corps volunteers. We are forever grateful for their support and service. To join the MRC, all you need to do is go to https://njlmn.njlinks.net and click on register as an existing or new MRC volunteer. If someone does not have access to a computer, we can print out a copy of the application, they can mail it in. And additionally, the administrator for the New Jersey Learning Management Network, her name is Cheryl Elise, and myself are available to answer any questions an applicant may have. Also, if there are specific questions regarding an MRC unit, I will direct the applicant to a specific MRC unit coordinator.
Great, and we will share the link as well with everybody after the fact. And I think one thing that I hadn't realized about the MRC until I started working with Julie is that non-medical professionals can volunteer and that there's plenty of really important work to be done in an emergency, but even in a non-emergent time for the MRC and around the state for health prevention.
I've had a number of the unit coordinators tell me that they could not have done it without their MRC, the community health volunteers, could not have done their vaccine pods.
Yeah, absolutely. And I know she's not next up, but I know Charlene can speak to that because she's had a lot of great volunteers there in Passaic County.
She has a wonderful MRC unit. It's led by Sandra Cameron. Excellent unit.
Great. Thank you so much. Kathleen, can you tell us how the Camden Coalition's role as a regional health hub, and maybe explain for everybody in case they don't know what a regional health hub is, how you work to bridge the gap between healthcare and public health in your community?
Sure, I'm happy to do that. Although I'll say that, like Paul, I think that our county health department had good relationships already. And so we were really trying to figure out how to help them. But the bridging had happened, I think, bidirectionally already, which helped because as Paul said, you can't wait for this for a crisis. But just so everyone knows, the regional health hubs were created in February of 2020 in right before the pandemic, right? So really prescient. New Jersey is becomes now very unusual in that it uses some of its Medicaid funding to fund nonprofit intermediaries that play a role between the Medicaid office and the ground. So our role as regional health hubs, there are 4 of us in Passaic, Newark, Trenton, and Camden, is to actually have a database that's available to social and health actors to provide assistance to state agencies as needed and to convene multiple diverse types of groups. So The regional health hubs did a variety of things, from being an extra pair of hands when needed, to making FEMA calls, to creating an ambassador program where people can go out and leaflet about vaccines. We did a myriad of things depending on our relationships, but they're really there to be an intermediary organization, and not just intermediary between health and public health, but also lots and lots of social services who are also out there, and through our coalition network, we could sort of be in touch with them too. So lots of things, happy to talk more about it, but really interesting intermediary role. And I'd say COVID allowed us to start to test that out and see what worked and what didn't with our local players, So I'll stop there.
Thanks, Kathleen. And Virginia shared in the chat box links to all 4 of the regional health hubs across the state. They're all wonderful participating members of the Quality Institute. So if anyone wants to connect with any of the regional health hubs, including Kathleen, just let us know. We're happy to make that connection for you. They do great work, and we're really proud to have them as members. And last up, Charlene, can you tell us a little bit about how you brought together stakeholders in Passaic County to establish a more unified response to the pandemic?
Thank you, Tyler. Good afternoon, everyone. I feel as if I'm a sort of a convener of all of the people who have talked before me, because every one of those speakers are bringing to the table things that we've been doing in Passaic County and throughout the state with our partners. So I think it was Paul who mentioned about relationships at the very beginning. And these relationships that he talked about and that I'm going to talk about existed for many years. Post 9/11, if you remember, about a week after 9/11, there were anthrax attacks on politicians and other members of the community. 5 people died and about 17 others were hurt by it. But it illuminated a need for us in public health and all of us in emergency response to recognize that emergency response is not just hazards such as storms and earthquakes and those kinds of events, but they can also be deliberate events using weaponized organisms, and we call it fondly bioterrorism. And so after that, the CDC actually began to fund in local health departments throughout the country emergency preparedness or bioterrorism focus groups, such as in all of the counties in New Jersey. So since then, 2011 to now, we have been doing exercises or drills or practices in how we're going to respond in an emergency. In order to do that, we had to develop and nurture relationships with all segments of the community. I have had to work with OEM very closely, our hospitals, our schools, other health departments, or superintendent of schools, human services directors, police, fire, you name it. We all had to begin to work together in these drills in preparation for hazard events. And so because of that, nurturing over 20 years, when COVID hit, prior to COVID hitting us here in Passaic County, we had already begun the conversation. And the conversation included having what we call a tabletop exercise, where we invited OEM, we invited the schools, we invited the hospitals that are in our community, we invited all of the health officers in Passaic County, all of the people who were stakeholders who were going to be a part of our response were at the table. Once we were able to get everyone together for the first one, and it's funny looking back because we were all cramped into the EOC. The EOC is the Emergency Operations Center. There was no such thing as social distancing. It was that, and so we were there, we laughed, we talked, we tried to, have an idea of how are we going to respond as a county to what's going to happen. I have to tell you, we had a second follow-up tabletop it was quite different. The second tabletop occurred on, I think it was March 16th. And for that one, we were half virtual and the other half in a big auditorium, because by then we had learned about the importance of social distancing. So everyone was invited, everyone came, and we discussed what our roles were going to be during this COVID response. Importantly, we talked about how we would set up testing, what that's going to look like. And I'll just backtrack. On March 15th, the administration received a call saying that we had to stand up a testing site within 1 week. We were able to do that at William Patterson because of that, those relationships that were already developed. We had an MOU, a memorandum of understanding or agreement to work at William Patterson as a drive-through testing site. That was already signed 10, 15 years ago. We had practiced, so we knew what we had to do. And so when my administrator said to me, we have to get this done in a week, what are we going to do? I said, not to worry, we have a plan. And so we literally executed that plan. In 5 days, we had our drive-through site set up, ready to go. And then we had to get our volunteers, because our health department, no one health department in Passaic County could do this work, because while this is happening, we are getting thousands of cases that had to be followed up on. Plus, we had all the other things that we do in the health department. So we were able to put out a call for volunteers. And let me tell you, this was one of the most heartwarming events of my entire career, because the outpouring of volunteer support was beyond belief. And it was beyond belief, not just initially, but it continues today. And so we ran that clinic for 3 months. We had about 40 to 50 volunteers every day in their moon suit, doing testing of strangers in a time when our positivity rate was 59.65. In other words, we were only testing people who we believed were sick, who had a prescription that said they needed to have a test. So people were taking their lives into their own hands by serving the community. And we saw that, and we've seen it from last year, March, to right now. I still have volunteers, not as many because people have gone back to work, but they're there, boots on the ground. The other health departments were sending their staff as much as they could. Again, they were swamped, as we all were, but everyone stepped up and everyone helped out. I met so many people who were able to provide us all the help we needed and then some. It was a phenomenal response. And I'll just piggyback a little bit on what Kathleen was saying about the Regional Health Hub. I am actually the chair of the Passaic County, the Healthcare Coalition of Passaic County. And so that body was able to provide us with Chromebooks, which we use for registration for our testing, and then later our vaccinations. They also provided us with UV light to decontaminate tents that were used in our testing program. And I mean, I could go on and on. Suffice it to say that the relationship piece, having the infrastructure in place before an event happened, is really what made our response so strong. So that's how I can explain our response to COVID-19.
Great. Thank you. And I think it's, if for anybody that's looking to do that type of work, I think you're a model to look at. And for anybody who wants more information, Charlene is the person to talk to. And I think I echo everybody's sentiments in thanking you for all of your work during the pandemic and otherwise. I am going to ask a few questions of the panel for anybody who'd like to respond, but wanted to ask the audience members, if you'd like to ask any of our panelists a question, please start typing them into the chat box now, and we will get to as many as we can after we're done with these full panel questions. So first one, what are some ways from your perspective that Quality Institute members, which is a multi-stakeholder membership that includes everything from providers to payers to academic institutions, how can our Quality Institute members help support public health today to better prepare for the next healthcare emergency that we know is inevitably coming in some form or fashion? Anybody who'd like to respond?
So
I can,
go ahead, Julie.
okay, excuse me. So as far as I'm concerned, we could not have responded as well as we did in New Jersey to the pandemic without the MRC volunteers and of course other volunteers. We always want to ensure our volunteers are safe and healthy before, during, and post deployment. About 63% of our New Jersey MRC units responded to a yes to a survey that I sent to them last week. Do you consider a post-deployment health assessment? Would that be valuable for you and your volunteers? So they felt that it would be valuable having a post-deployment health assessment. We don't want to just say, thank you for your service and goodbye. We want to make sure that everyone, again, is safe. And you have to remember that many of these volunteers, the majority of these volunteers essentially worked full-time, day in, day out. Most of them worked outdoors in all different kinds of weather conditions, snow, ice, hot weather, cold weather, just all different kinds of conditions, rain, wind. It was very windy. A lot of tents were knocked over. So, if someone, we're not forcing anyone, but we want to make sure we're offering it to the volunteers and the unit coordinators. And as Charlene had said, the unit coordinators, they are part of the health department. So they're doing their regular job and then they're doing their MRC role. So, they're working days, evenings, weekends, holidays, so it was very intense for a very long time. So we want to make sure that everyone is safe and healthy. And then of course, training opportunities, opening up training opportunities. I've had a number of volunteers and unit coordinators say, you know what, we're ready to do the training in person. We're ready if we can do online, but we're ready to do in-person training as well. And then of course, it's important to maintain a robust cadre of volunteers because you can't ask the same people to help all the time. Some people you need some time off, you have other obligations. So we need to maintain, some people, like what Charlene had said, went back to work and then others step in to fill that void.
And Julie, just to follow up on that, do you ever have organizations that volunteer for a particular event altogether, or is it just individuals that register to volunteer? Like, could an organization come to you and say, we want to volunteer on this day with this many employees?
That actually did happen, specifically in Ocean County. The physicians, I forget the exact name, but it was like, it was physicians, I forget the Asian physicians, but they work very closely. I can get the full name for you, but they worked very closely with the Ocean County MRC. So they became essentially MRC volunteers. But what everyone has been saying, you need to have these relationships ahead of time because there were some organizations who came to us and they wanted to serve, but it was like, well, okay, you really need to join the MRC because remember, deployment is based on the unit coordinator in conjunction with their administrators. So, they're talking, like, for example, Sandy would be speaking with Charlene, and then Charlene is coordinating this with their county OEM person. So the deployment is based on, the volunteers are local community assets, and deployments are based on the unit coordinators and their administration. So they decide, what deployments and which volunteers will be deployed. So, It really makes sense to have those relationships ahead of time because otherwise you're struggling back and forth. No, we want you to join our organization. No, we want you to join out. Back and forth. No, ahead of time. Get these relationships, the memorandum of agreement ahead of time.
Great. And I know training is such an important part of it. And Charlene, I know you wanted to chime in here. I think it was you that had mentioned to me about some training that was going on in your community on blood loss. And I don't know if you can speak to that and the training that you're providing to community members there.
Sure. So I'll take this part first and then I'll go back to the original question. So one of the things that we are required to do and that we do very happily because benefits our organization as well, is to provide ongoing training for our volunteers, particularly the volunteers that are professionals that need continuing education units or nursing units or chess, whatever it is, for their own professional growth. So we are able to partner with other organizations or purchase services. And the one you're talking about, I believe, is Stop the Bleed.
Mhm.
So I'm sure all of us are seeing how many events, mass shooting events are taking place throughout the country, and nobody thinks it's going to happen in their community. But we've seen that it does happen in communities where it is not expected. But the one thing that we've learned, and I've heard it from police officers from throughout the country that have come to our trainings, there's one common theme that comes back, and that is that many people die because they bleed out. And they bleed out because nobody present has the presence of mind to use a my brain is dying right now. Somebody help me.
Tourniquet.
Tourniquet. So the Stop the Bleed is really an opportunity to learn how to respond and to stop the bleed, because that could actually save lives. We also do, 2 days ago, we had CPR training for our MRC volunteers. Some of them needed to renew their ALS training, so we would provide that. Whatever it is that they need, we do mental health first aid, psychological first aid, all kinds of trainings, and we're always open to new ideas, so that there is an incentive, a value for those volunteers that are giving up so much of their time and talent to us, that we could give them back these small things that are actually important to them. So it's a symbiotic relationship. I mean, we're getting most of it, we think, but we're able to give them something else in return. Now, regarding that original question you asked about the Quality Institute members providing a service to help us better in public health, one of the areas that I think we could really use some help from your educational members is help with data management, data analysis. We have a lot of information in the health department, but we really don't have the resources to manage that information. So I think for our universities and people who have that kind of skill set, that could really be useful in all of the 100 health departments that are in New Jersey.
And Charlene, I know you had told us that I think it was either during a testing site or a vaccination site, you had a volunteer that helped you stand up a registration platform, somebody that just had the skills and happened to be able to serve you in that way. I think it's just such an amazing story.
So it was an MPH student at Rutgers who had volunteered. And so one of the things that my MRC coordinator does is when you come to volunteer, she signs you up immediately. And so he came to volunteer, and he also became a contact tracer later on. So we had our system in place. We did it the best we could based on the plans that we had drawn up 10, 15 years ago, based on how we had practiced with William Patterson. And our registration process was just not moving as fast as we would like. I mean, on our biggest day, we had 3 large tents. Each tent had 4 individuals. And, we had all kinds of stuff, but it just wasn't moving as well. So he said, well, why don't we do this? And he created email addresses his innovation changed our process right in the middle of everything and moved along the line tremendously. So we called him our star registrar because it was just something that nobody had thought of. He saw it. He thought it was going to help. He asked us if he could do it. I said, sure, try it. And he did it. And that was a volunteer. We were able to hire him as a contact tracer. Actually, he still works for us now as a contact tracer as well.
That's amazing. So I think long story short is there's no shortage of things to be done and help that people can provide from the smallest thing to, creating a new platform for helping you with technology there. Did anybody else want to comment on that question?
Sure. So just acknowledging the power of the MRC. So we were also advertising the MRC and the website link for people to sign up, because we had a huge need for surveillance and data folks. So like our local universities had epidemiologists and biostatisticians on hand to help. So we were just like referring them to the site to sign up. And then once they got clearance, then we were bringing them on to do various data analyses and things like that for us. We also had an agreement with one of the other universities where there was a data sharing agreement. So they were able to run some de-identified data for us and all of that. But just having that hub of having an MRC resource to share with the media, to share with the public, to divert people to, because again, noting that it's not just clinical, or people that were assisting with the testing, that we also had data needs. And so we needed to bring people on board because, most health departments have been so underfunded that we don't have full on like epi departments, or, even for our outreach and public relations, we didn't have a PIO until April. So just bringing people on board to help with outreach and marketing was huge too. So just using the MRC to get those volunteers on board. And once we got CARES Act funding, then we were able to convert those people on as temps. As noted, bringing that person on that helped and bringing them on as a contact tracer, we did the same thing. We were converting a lot of people into temp positions. And now as things have kind of transitioned, and even though I'm no longer at the department, many of those temp workers have been, their term has ended, but some of them have been brought on as actual city employees. So just seeing that chain of volunteer, temp to actual employee, and seeing how that process was made available by having an MRC resource available in the community is huge.
It's amazing. And in your new role at Trust for America's Health, we cited several of your reports in our COVID-19 action plan that really detail how public health is funded or lack thereof. So Virginia, if you can put that link into the chat box, or we'll certainly share after, folks should really take a look at how public health is funded across the country and how there really is a need for more resources there.
Mm-hmm. Thank you. Yes, we've been scrambling to convene partners and to get reports out because we know that time is of the essence. There's some very rare funding opportunities that we want to make sure elected officials have the information to make informed choices instead of just going with the squeaky wheel and kind of making funding decisions that way. So thank you for addressing that.
Absolutely. Thank you. Kathleen, did you want to comment?
Yeah, I just wanted to say that I love all the volunteerism and it's amazing. But I think that a role that the Quality Institute could play is to really figure out, where we had to use volunteers and we needed those positions, right? So Quality Institute, now I sit in a regional hub that sort of has a regional perch, but you all have a statewide perch. And I see as an intermediary organization. And so it'd be amazing to look at MRC's records to see where they were filling in for things that would really should be a funded position. And that's great data that MRC has for a local public health department or a state department to make the case for FTEs.
That's a great point, Kathleen. Thank you. And yeah, we would love to serve in that capacity and are getting more involved with our public health associations across the state and having them join the Quality Institute so we can continue those conversations. Great. And so I'm not seeing any questions from folks in the audience. So if you do have any, please pop them in. We've got about 10 more minutes. So I'm going to ask another question while we're waiting to see if we have any audience questions. So next question for me is the use of technology, which we just started talking about, and in some cases, the lack of access to technology has played a big role during the pandemic. Moving forward, how can we use technology to improve our response to public health emergencies? So I think that goes for anything, for a data platform to help with testing and vaccinations, to telehealth. In your respective roles, is anybody seeing where there's a use for technology moving forward in public health?
I'll start with it. We need a true statewide MRC volunteer registry. We need a registry that has a deployment tool, a volunteer timesheet, a scheduling system, an area where you can post volunteer opportunities. We need access to social media. We need a system that tracks volunteer training and a system that you can send email blasts. I sent an email blast to all active approved volunteers about 3 weeks ago, and there was a glitch in the system and it sent the same email 4 and 5 times. And some folks were a little cranky, this is, stop spamming me. So we need an honest to goodness volunteer registry system.
Right, so technology upgrades too, I think is equally important.
Brandy new, we need a registry.
Yeah, and Julie, isn't there a nationwide system that a lot of other states use? Is that right?
No, there are systems out there, and I've spoken to other states about what they use, what's good about it, the strengths and gaps. And so, but there's not, I wish there was one that the federal MRC could say, this is the system, here it is, but that's not the way it is. But unfortunately, we have some ideas, but we really need to have an honest to goodness, true volunteer registry.
Got it. And I know we had mentioned, I think in the action report as well, the need for automated communication between yourself and the professional boards at the Division of Consumer Affairs to ease the process and make sure that if they are current healthcare professionals, that their licenses are up to date and where they need to be. So I know that was something that we had discussed also.
Right. We need to be able to very efficiently streamline the process with the New Jersey Division of Consumer Affairs. So if I say I'm Dr. P-Tex MD and I'm not, we need to be able to credential and vet that person, ahead of time. So it would be a big help to have a system that we are kind of connected with the New Jersey Division of Consumer Affairs.
Absolutely. Anybody else? Technology tools that you're seeing?
Go ahead, Jeannette. I want to hear from you because we can talk amongst ourselves in New Jersey.
Mine is more so about the funding to procure the technology. So, there's always like excuses as to why technology hasn't been purchased or why it hasn't been updated. Even like we're seeing like the immunization registries, for instance, or electronic medical or health records. Like the Milwaukee Health Department didn't even have a health record, electronic health record. So we weren't able to run our own testing sites from the beginning. So it's just like little things like that. There's always this like scraping up or excuses as to why there's no money for public health technology investments, but there's money for everything else, right? So it's like our need to continue to develop those relationships with elected officials and really help to translate the need for why there needs to be investment in technology for healthcare and public health. And aside from that, even like the replacement costs. So like, I'm in a condo right now, you have your reserves. How are we putting money aside to pay for upgrades and replacements down the road? Because we're going to have to do that. So we're not scraping 5 years from now for new upgrades once all of this COVID money goes away. So it's just something that continues to pop up, and a need for there to be like an emergency public health fund. When I was the health officer for the University of Wisconsin, we had a public health emergency fund. And the whole point of that, it wasn't a lot of money, but the whole point of that was so we would have funds available if we needed to purchase or deploy things quickly. We weren't jammed up requesting money or waiting for approvals. We were able to spend as the need called for us to do so. So those two things I think continue to be a concern of mine. And then I guess the last would be compliance, that there's some type of omnibus or inspector general or something along those lines. It's making sure all of this money that's coming in is being used fairly in an equitable manner, that it's not going to, people's pet projects or businesses, that it's actually being used to help the communities that we're serving. So those would be my 3 points to make sure that we're stressing.
I think you've listed them very well. I think we need to, I'm not sure who we have to talk to, but there needs to be more funding for public health. Right now, this is public health is in the spotlight. But what what changes are going to happen as a result of COVID-19? How are we going to shore up public health going forward? It's fantastic that we have the MRC. It's fantastic that people have come forth when we needed them, but really we need to have the infrastructure in place so that the MRC would be the icing on the cake, not the cake, right?
Mhm.
So there needs to be systems in place to be able to provide public health throughout the country. One of the issues that we're having right now, and I'm sure it's throughout, is many people who were, let's say, in Florida or Arizona or somewhere else received their first vaccine somewhere else. And so they're coming back home to New Jersey, or they were moved because a relative moved, whatever the reason is, but they need a second vaccine. And so in order for us to give them a vaccine, we need their medical records. There is no one record keeping place where we can just go in and check and see John Smith from, Buck Street in Ohio received their first vaccine at Ohio State. So in order to do that, we have to jump through hoops to try to get that person a shot. There needs to be a lot more uniform resources throughout the country. But I think the very first step is funding local public health wherever it is throughout the country, so that we have a strong infrastructure for when the other pandemic or other hazard hits, we're not all scrambling for support.
Absolutely.
I'll just say we were able to, in Camden, bring our the Camden County Health Department onto our HIE, our Health Information Exchange, so that their contact tracers could look at that. I think that and I think I see Dr. Nwako on here, and he would have so much more to say about this than me, but, there wasn't the tech budget, to really do that much. And he wants to do so much more. He sees what the analytics that come out of things like that, but, it requires staffing.
Absolutely. Health IT infrastructure.
Can I just say something too? We're all taxpayers, and I know I'm frugal with my money, I'm frugal with your money, and we want to be good stewards of money. And so we're very careful with how we spend. We don't want to waste anything. And we're very grateful when we do receive funds to do something, any resources or funding. So we're very grateful, but we are very good stewards of funding. And again, we try to take, make the best use of that money. So I just wanted to make sure I stress that. And I guess the last thing I wanted to say is that, we can do a lot on a shoestring, but we do need the shoestring.
Thank you, Julie. And I like the cake analogy, Shirley. We have about 2 minutes left, so I'm not seeing any questions from the audience, but just wanted to see if anybody else had any other comments that they wanted to make. I think this is such a helpful discussion, and I know it generated a lot of thoughts for me about work that we could be doing at the Quality Institute with our members. So if anybody has any closing thoughts, we have a minute or two left.
Tyler, the only thing that I would add is, we talked a lot about relationships and relationship building as a key here. And I would just encourage, anyone who is not participating in their regional healthcare coalition to do so. I mean, we've got regional healthcare coalitions that the Department of Health and NJHA established in late 2019, right as the pandemic struck. And, their goal of those coalitions is to align our public health partners and anyone in the care delivery space. So acute care, long-term care, our federally qualified healthcare centers, home care and hospice, EMS, and emergency management, to have those ongoing conversations about emergency planning and exercising and gap analysis, and all those kinds of things that builds these relationships. So I would encourage anyone who has not had the opportunity to participate in their regional coalitions to do so. I've got the pleasure of leading the Southwest Coalition here in our area, and I would encourage anyone to jump in and attend those meetings.
Thank you, Paul.
Can I just add that I want to say a shout out to our retirees. The New Jersey Division of Consumer Affairs, they allowed individuals who recently retired within the past 5 years to reactivate their healthcare licenses at no cost. for the duration of the state of emergency. And that was brilliant because we had the best people come. I mean, they were wonderful, these retirees. We had about 60% of our MRC volunteers serve as vaccinators. And of that, about 43% were retired health professionals. So that was brilliant. The other thing I want to mention is there was an executive directive that expanded who could give vaccines, and that included paramedics and dentists. And I had so many positive things that the MRC said about the dentists that, oh my goodness, they're fast, they're really good. And so that was brilliant to do that. I know that they would not allow veterinarians to give shots. And I had several veterinarians call me and say, listen, if I can give a shot to a barking dog that's trying to bite me, I can vaccinate a human. So, that wasn't possible. Maybe next time around.
Absolutely. Thanks, Julie. And I think we'll end there. But as I mentioned earlier, we're going to have the recording of this presentation up on our website later today. I want to thank all of you, Paul, Julie, Jeanette, Charlene, Kathleen, for joining me. This was great. And thank all of our audience members for participating. Really appreciate it. Have a great day, everybody.
Thank you.
Thank you.
Thanks, everyone.
Thank
Thank
you.
you.
Bye-bye.